Great. We're going to start. Well, good morning, everybody. We're going to start with our fellow research presentations, which will be ongoing here for the next several weeks for grand rounds. Starting off today, we have Neil Bakshi, Matt Belton, and Matthew Christie with foot and ankle, hand, and total joints, respectively. Neil's going to start us off. We're going to shoot for about 15 minutes and then for about 5 minutes for discussion. So if you have any questions or comments that come up, obviously use the chat if you want. That's easy. Or save your questions till the end, and then we can do them audio. Okay, with that, go ahead, Neil.
Great. All right, like Dr. Tischer said, I'm Neil Bakshi. I'm the Ortho Foot and Ankle Fellow this year. I'll be talking about my research presentation titled An Association Between Hindfoot Alignment and First Metatarsal Axial Rotation. Big thank you to all my co-authors who are listed here. Special thanks to Chris Arena, who's last year's fellow, who did a lot of the foundational work for my project. And then big thanks to Dr. Saltzman as well, who is my mentor and PI for this project. This project's currently also submitted to Foot and Ankle International. So a little background before we get into my project itself. There's a clear linkage that's been demonstrated between forefoot and hindfoot alignment. You can see this with the Coleman block test demonstrating a forefoot driven hindfoot varus deformity, as well as a compensatory forefoot supination deformity that's often seen with hindfoot valgus and flat feet. There's no demonstrated linkage that's been shown between hindfoot alignment and first metatarsal axial rotation. The reason why that first metatarsal axial rotation may matter is it's been implicated in hallux valgus or bunion deformities. It may also be responsible for recurrence of a bunion after a uniplanar correction, and it may affect your overall push-off and tripod function. So here's a patient example demonstrating this. This is a 55-year-old female with severe hindfoot valgus, a bunion, and a first ray pronation deformity. You can see on the hindfoot alignment view on the bottom left that there's clear severe hindfoot valgus. On the bottom right AP foot, you can see there's an increased IM angle and a bunion. And then you can also note that the first metatarsal head is rounded on the lateral side, indicating that there's a first metatarsal pronation or axial malrotation deformity. And that's confirmed on the weight-bearing CT scan that shows the sesamoids over laterally and the first ray rotated. So the question that we had going into this study was, is there any association between hindfoot alignment and first metatarsal axial rotation? Clinical significance of this, and the reason why it matters is there a possible differential impact on how we should be treating first ray alignment? If there is a rotational deformity, should we be correcting this in the surgical treatment of cavovarus or planovalgus deformities? And ultimately, does that make a difference for our patients? So our hypotheses going in, hindfoot valgus alignment would be associated with first metatarsal pronation, and hindfoot varus alignment is associated with first metatarsal supination. To do this study, we looked at 761 weight-bearing CT scans from June 2015 to June 2018, and then applied the following exclusion criteria. So if the same patient foot was obtained multiple times using weight-bearing CT, the duplicates were thrown out. If the weight-bearing CT was not obtained within 6 months of the weight-bearing plane radiograph, those patients were excluded. Patients were excluded if they had prior foot surgery, prior foot trauma, or significantly dysmorphic features like a hindfoot coalition. And then we ruled out patients with mild hindfoot malalignment, and we'll get into a little bit in a few slides on how we did this, but basically patients that were within a half a standard deviation from the mean were excluded because we wanted to focus mostly on patients with more severe hindfoot malalignment. Here's a flow chart just demonstrating how we got to our ultimate patient weight-bearing CT scan numbers. Started with 761 scans, applied those exclusion criteria, and ended up with 196 weight-bearing CT scans. So in order to do this, we had to measure hindfoot alignment, and we did that with the calcaneal moment arm measurement, which has been published in the literature and is one of the most common ways of measuring overall hindfoot alignment. So we had 3 independent observers measure hindfoot alignment using this measurement. To do this, you basically find the coronal weight-bearing CT scan slice where the tibial diaphysis is at its widest. Create one circle that's tangent to the outer cortices of the tibia at the top of the image, and then another circle that is tangent to the distal tibial plafond, and then create a line that runs through the center of those circles, basically bisecting them, and that's your tibial longitudinal axis. And then you find on the coronal weight-bearing CT, you find the inferiormost point of the calcaneus, and you draw a horizontal line from that to the tibial longitudinal axis. And that gives you your calcaneal moment arm. Valgus in our study was shown to be a positive number, and varus was a negative number. So once we calculated the calcaneal moment arm mean and standard deviation, we created 6 different groups based on this. So a moderate, substantial, and severe varus and valgus group. So again, the patients that were within a half a standard deviation of the mean were excluded. Patients that were a half a standard deviation to 1 standard deviation from the mean were the moderate varus and valgus groups. The patients that were 1 to 2 standard deviations from the mean were the substantial varus and valgus groups, and then the greater than 2 standard deviations from the mean were severe varus and valgus. And you can see how the patients break down here. After that, we needed to measure our first metatarsal axial rotation. We did that with 2 different methods, the Saltzman angle and the Kim angle, using weight-bearing CT. These are 2 of the more commonly utilized measures of measuring first metatarsal axial rotation. They were initially described on weight-bearing plane radiographs, but we've adopted them to CT, as well as a number of other studies have. So the Saltzman angle, you create one line that's parallel to the floor, and then a second line that is tangent to your medial and lateral sulci on the bottom of your first metatarsal head, where the medial and lateral sesamoids would sit. The angle that's created between that is your Saltzman angle. If the first ray was in pronation, that was termed was a positive value, and supination was a negative value. The Kim angle, relatively similar, but uses 2 lines on the first metatarsal head, one that connects the superior medial and superior lateral corners of the first metatarsal head, and then another line that connects the inferior medial and inferior lateral corners of the first metatarsal head. You draw a line that bisects that, and then the angle that's formed between that line and a line that's perpendicular to the floor then gives you your Kim angle, or your overall rotation. And then we took measurements for the 1-2 IM angle on weight-bearing plane radiographs. Just for a little background, normal IM angle is less than 9 degrees. You can clearly see the one picture on the left has a normal IM angle of 7. And the picture on the right is actually the patient that we showed at the beginning. So an IM angle of 16, again, with that rotated metatarsal head showing that rounded lateral side. We measured the Meares angle on weight-bearing plane radiographs. To do this, you basically go to a lateral x-ray and take the tibial axis and the first metatarsal axis and create the angle that's between them. Apex dorsal was any number that was greater than 180 degrees. Apex plantar was any value that was less than 180 degrees. Picture on the bottom clearly shows a apex plantar Meares angle, which you would commonly see in a planovalgus deformity. So we also looked at the lateral head round sign that was described by Okuda et al. On weight-bearing plane radiographs. To do this, you create a circle that's essentially matches the first metatarsal articular surface, and then find the distance from the lateral edge of the first metatarsal head to the edge of that circle. If that value was between 0 and 1 millimeters, it was considered a round metatarsal head. If it was between 1 and 2 millimeters, it was an intermediate metatarsal head. And if it was greater than 2 millimeters, it was an angular first metatarsal head. So we did intra-observer and inter-observer reliabilities, and then also looked at our categorical variables with the Pearson chi-squared test, and then used the Spearman correlation coefficient for looking for any correlations between our evaluated variables. And all of the statistical testing was set at a p of less than 0.05. So again, we looked at 196 weight-bearing CT scans, average age 52.6. The mean calcaneal moment arm was 6 millimeters in the valgus direction. The mean first metatarsal axial rotation was 7.7 degrees and 2.8 degrees with the Saltzman and the Kame angles in the pronated direction. And then the average Meary's angle was 182 degrees, or 2 degrees in the apex dorsal direction. We found a significant relationship between hindfoot alignment and first metatarsal axial rotation, where hindfoot valgus was significantly associated with first metatarsal pronation, and hindfoot varus significantly associated with first metatarsal supination. And as those hindfoot deformities worsened, so did the axial malrotation of the first ray. There's also a significant association between first metatarsal axial rotation and the IM angle, where as the IM angle increased, the first metatarsal pronation also increased. And there was a significantly inverse relationship between Meary's angle and the first metatarsal axial rotation, where as the Meary's angle went more apex plantar or decreased in its quantity, the first metatarsal axial rotation increased or went further into pronation. So after we did a further subgroup analysis, we realized that there's actually within our hindfoot varus and valgus groups that there's separate cohorts of patients. Basically, in the hindfoot valgus group, for example, there's patients that have a normal Meary's angle and they had normal first metatarsal rotation, as you can see in the graph on the bottom left. And there's also a cohort that had a significantly abnormal Meary's angle that also had an abnormal first metatarsal rotation. So once we broke it down, we realized that the group with an abnormal Meary's angle clearly had that link between the hindfoot and the forefoot rotation that another cohort of patients with hindfoot valgus did not have. And this is shown right here with the person on the left having hindfoot valgus, a normal Meary's angle, and normal first metatarsal rotation. And then the person on the right having hindfoot valgus and an abnormal Meary's angle and abnormal first metatarsal rotation. It's unclear what's causing these two different groups within the hindfoot valgus group. One of the theories that we thought was there's clearly some sort of accommodation that's occurring through either the Chopart joints, the TN and the CC joints, or further on in the midfoot, where if you have an abnormal Meary's angle that's being carried over to the forefoot, and if you have a normal Meary's angle, that's clearly not being carried over. We also looked at the round sign of Okuda and found a significant association between hindfoot alignment and the first metatarsal round sign, where the hindfoot valgus patients had a significantly higher proportion of round metatarsal heads rather than angular, and the reverse was true for hindfoot varus patients. So in summary, there was a moderately strong correlation between hindfoot alignment and the first metatarsal axial rotation, with hindfoot varus being associated with first metatarsal supination and hindfoot valgus being associated with first metatarsal pronation. There's a moderate correlation between the IM angle and the first metatarsal pronation, and a moderately strong inverse correlation between hindfoot alignment and Meary's angle. So this study demonstrates a clear association between hindfoot deformity and first metatarsal rotation. In my eyes, when I look at this study, while it does demonstrate that association, I think it gives us more good questions to ask moving forward than it does, truly definitive answers. But some of the questions that I think that we had after we finished this study are, is this rotational malalignment corrected with our current treatments for planovalgus and cavovarus feet? Should we be doing derotational fusions or osteotomies of the first ray to correct the axial malrotation? And does correction of this first ray malrotation even matter? Does it result in better functional outcomes for people? And we don't have answers to those, but it definitely demonstrates the foundation for answering these questions in the future. So limitations, this is a retrospective study. We also didn't evaluate for causation. So it's unclear if the hindfoot deformity leads to the first ray rotation or vice versa. We also can't determine whether correcting the hindfoot deformity corrects the forefoot deformity. And again, we did not obtain any patient-reported or functional outcome scores as a part of this study. Thank you.
Okay, thanks, Neil. We have a couple minutes for questions before we're going to start with Dr. Belton.
So
Neil.
oh, sorry. Neil, I might just ask, is it really first metatarsal rotation, or since you're just measuring the distal aspect of that, is this really a proxy for deformity in the midfoot?
I think that's a little bit unclear. It may be, but there's definitely been studies that show that a lot of the change does occur through the metatarsal shaft itself. But you're absolutely right. There may be a cohort of patients where there is a change through the first TMT joint rather than through the bone itself.
Florian, do you have a question?
Yeah, thanks. Nice work, Neil. What do you think would be sort of good follow-up studies on this? I mean, where would you take this information to?
Yeah, so I think the next thing that I want to try to figure out is whether to get, if we got post-op CTs on people, so basically where we had pre-op and post-op CTs, I think it would be valuable to know what happened with the first metatarsal axial rotation after either a cotton or a first dorsiflexion metatarsal osteotomy. Basically, do the corrections that we do with fixing the hindfoot and elevating or dropping the first ray, does that change your first metatarsal rotation? So that's one thing I definitely want to do. And then just evaluate whether, the people that we do flat foot reconstructions where we do a first TMT fusion rather than a cotton, where we have the ability to derotate the first ray, do those people do better?
Okay. Thank you, Neil. Any other questions before we move on to Dr. Belton's presentation? Okay.
All right, can you guys see my screen okay?
Yep, you're good.
Perfect. All right. So my name is Matt Belton. For everyone I haven't met, I'll be presenting on patient satisfaction with orthopedic surgery virtual clinic encounters with a particular analysis of factors that impact the Press-Ganey survey. Just a list of the authors and contributors. I'd like to thank Dr. Wong, Tischer, and Dr. Kasmers for really helping guide this study and streamlining it. I've definitely changed the way I've viewed the literature and performed research, and the way I'll perform research in the future due to their contributions. So here are just a few reviews I found for hand surgeons here at the University of Utah regarding virtual visits. One in particular, I liked the doctor, but I did not like the virtual visit. And another, it was a good experience, but I'd much rather see him in person. It's just not the same, especially when it's about your joint. As you can see, the patient's consternation came not from the provider, but rather the experience. And if you know anything about the online rating industry, 4 stars, it's just really not going to cut it. With the onset of the COVID-19 pandemic, the process of shifting clinical care to telemedicine visits has been hastened. Orthopedic care has been limited in many practice settings, primarily to urgent or emergency visits or surgical procedures. Many elective surgeons have been forced to venture into finding new applications for telemedicine visits that have not been previously fully developed. Although a virtual orthopedic examination may lack the vital elements of palpation and dynamic testing, the current situation necessitates that we utilize available resources to optimize the quality and outcome of patients' virtual visit. Under the Coronavirus Preparedness Response Supplemental Appropriations Act, particularly Section 1135, Section 1135 waiver, the Centers for Medicare and Medicaid Services broaden access to Medicare telehealth services so beneficiaries can get a wider range of services from their doctors and other clinicians without having to travel to a healthcare facility. On March 6th, 2020, Medicare began temporarily paying clinicians to furnish beneficiary telehealth services residing across the country. Before this announcement, Medicare could only pay clinicians for telehealth services such as routine visits in certain circumstances. Particularly, the beneficiary getting the services must live in a rural area and travel to a local medical facility to get the telehealth services from a doctor in a remote location. In addition, beneficiaries generally could not get telehealth services in their home. Under this Section 1135 waiver expansion, a range of providers, including doctors, nurse practitioners, and licensed social workers, can offer a specific set of telehealth services, including evaluation and management from the patient's home. So can we be successful as clinicians in the area of telemedicine? Here is a 5-star review from one of our hand surgeons regarding a virtual visit. And it states, this appointment was conducted over FaceTime and it checked off all of my boxes for being thorough. Prior to the ongoing pandemic, literature has explored the role of telemedicine in orthopedic consultations with good results. A randomized controlled trial based in Norway compared video consultations with standard orthopedic visits and included new referrals in the outpatient setting. The authors in this study reported that it was safe to offer these video-assisted consultations for select orthopedic patients with no adverse events reported. The Veterans Affairs had reported success back in 2012 treating patients with orthopedic trauma, particularly related to those in fracture management. In addition, there have been systematic reviews regarding telemedicine-based rehabilitation and showing strong evidence in favor for this method for postoperative hip and knee arthroplasty visits. Even the utility of virtual goniometers during telemedicine visits have been validated in prior studies. Russell et al. Reported on the use of internet-based goniometers to assess knee range of motion and found that face-to-face measurements and internet measurements showed high intra and inter-rater reliability. In addition, assessment of function has been found to be adequately performed during virtual evaluations of the shoulder. In one study, the mean constant score for the video assessment was just a half a point lower than that for an in-person assessment, and concluded that video evaluations resulted in reliable estimates for shoulder functions. Despite all of these successes, challenges have been reported, particularly with the implementation with the elderly population. However, these patients may benefit the most from televisit capabilities because of their limited mobility and the higher risk of morbidity associated with the current pandemic. And with the increasing access to information on the internet, people have taken to the internet to review their schools, their favorite restaurants, and now even their physician. Increasingly, physician compensation is being linked with patient-reported outcomes. Now, the question many of you may have is, one, are virtual visits here to stay? And if so, how do I improve my patient satisfaction in the telemedicine setting? Now, addressing the former question, a quick literature review across many of the medical journals will show you that this is a particular topic of interest. And the general consensus is that telemedicine is here to stay in some form or another. The proverbial cat is out of the bag. But telemedicine regulation has been slowly chipped away over the last decade, stemming from the long-standing concern that state licensing boards are overly focused on protecting their members from competition rather than on serving the public interest. The Constitution empowers the federal government to preempt state laws that interfere with interstate commerce, and Congress has carved out certain exceptions to states' exclusive jurisdictions over licensures, specifically in the context of federal health programs. For example, the VA Mission Act in 2018 requires states to allow out-of-state clinicians to practice telemedicine within the Veterans Affairs system. In addition, Congress has made proposals which will allow physicians to apply for a national license and policy that permits interstate medical practice. In some studies, greater than 40% of patients expressed interest in more frequent use of telemedicine. So coming to my study, we investigated the patient factors that could influence the patient experience. The Press-Ganey Outpatient Medical Practice Survey is one metric that has notable prevalence in this arena of measuring patient satisfaction. It has been used to assess patient or physician performance, modify provider compensation, and in general to inform systematic changes on how healthcare is being delivered. In terms of virtual visits, there's almost no research defining those patient characteristics that predict satisfaction. An improved understanding of these factors may aid in their interpretation of scores and provide an opportunity to improve patient satisfaction. Through this research, we hope to investigate factors that may influence the outcome of these scores on a university-wide interdepartmental level with the overarching goal of providing meaningful research to improve quality of care by testing the null hypothesis that no patient or clinic visit characteristic affects patient satisfaction of hand surgery patients in the virtual scenario as measured by the Press-Ganey Outpatient Medical Practice Survey, total score, or the provider subscore. So adult patients greater than the age of 18 were evaluated by 5 hand surgery providers between April 2020 and November 2020 for only new patient clinic visits performed via virtual means, driven by our pandemic-related precautions at a single tertiary academic medical center, and were stratified by the Press-Ganey Outpatient Medical Practice Survey for virtual visit total score and subscores. A retrospective chart review allowed us to collect demographic variables such as gender, BMI, ethnicity, and race. Pertinent social history data points were collected, including smoking and drinking history. Primary diagnoses were collected as well and stratified according to common designations such as tendinitis, fracture, arthritis, nerve mass, or Dupuytren's. We also collected data through the area deprivation index. We calculated the distance from the closest treatment facility and also the final recommendations at the conclusion of the virtual visit, including whether surgery was offered, an in-person visit was recommended, no follow-up required, or other therapeutic or diagnostic modalities such as advanced imaging, splinting, or therapy. Just going back to social deprivation, this was assigned to each patient using the 2015 Area Deprivation Index. This index is based on a measure created by the Health Resources and Services Administration over 2 decades ago for primarily county-level use, but refined and adapted to the census block group neighborhood level data popularized by Amy Kind and her research team at the University of Wisconsin-Madison. It allows for rankings of neighborhoods by socioeconomic disadvantage in the region of interest. It includes factors for theoretical domains of income, education, employment, and housing quality. And it can be used to inform health delivery and policy, especially for the most disadvantaged neighborhood groups. The ADI evaluates 17 factors that influence the socioeconomic factors based upon a person's given zip code +4. And this spreads out to about a block of 10 to 15 homes. The total and subscore were statistically analyzed with assistance by the Study Design and Biostatistics Center using a Tobit regression model on the continuous score outcomes to account for the substantial ceiling effect of this scoring system. No covariate selection was used. So just a quick overview of the Press-Ganey metrics. As part of a quality improvement initiative, the University of Utah has contracted with Press-Ganey Corporation to measure patient satisfaction in all outpatient encounters. All patients who complete an encounter in the hand clinic are contacted automatically by email following their clinic appointment with a request to complete the survey electronically. Those patients who do not complete the survey within 5 days are sent another email, and links are live for 30 days. The data is compiled by the Press-Ganey Corporation. Generally, the general survey consists of 24 questions grouped into 6 domains as seen here on the left. But the Press-Ganey Corporation has made a change for telemedicine visits, reducing it to 12 questions and adding this additional telemedicine technology question domain. More recent peer-reviewed publications confirmed satisfactory psychometric properties of the survey for measuring patient satisfaction. However, a high ceiling effect is often observed. So going quickly through our results, from November April to November 2020, 96 new hand patients were seen virtually, meeting the above criteria, consisting of 52 men and with a mean age of 54 years. The primary diagnosis include traumatic nerve injury, hand arthritis, fractures, dislocation, and hand mass. Common treatment recommendations included small and joint injection, in-person evaluation, surgery, and splinting. And the national percentile for ADI was 32, with the average distance to the nearby clinic being 97 kilometers. So throughout all of this data, sorry, I'm trying to advance. So using the Tobit regression modeling, we came down to 3 really salient points, and that being that the total and subscore were not statistically different in terms of satisfaction. What we did find interesting was that the current smoking history and increased age were significantly associated with higher patient satisfaction, whereas recommendation for an in-clinic or in-person clinic evaluation was associated with a lesser patient satisfaction. Other factors such as socioeconomic level, BMI, primary diagnosis, and insurance type were not statistically significant. Generally speaking, patients reported high satisfaction with the telemedicine encounters. Our main finding that we did find that social deprivation was not an independent predictor of decreased orthopedic outpatient satisfaction as measured by the survey, but we were able to reject our null hypothesis as was observed by both the total and subscores that were independent for several factors to show a large magnitude of impact on patient satisfaction, including patient age and clinical recommendation. Our study is limited by those inherent to the survey, specifically the documented non-response bias. Previously, a study found that responders differed from non-responders regarding age, sex, insurance type, and orthopedic subspecialty. In addition, at our institution, response rates range between 9 and 17%. Another limitation of our study is that we only include first visit new patient encounters. Patient satisfaction with their encounter may be completely different if they refer a routine follow-up or a post-op visit rather than their first time addressing their problem. Future studies may include all orthopedic surgical subspecialties, determining whether telemedicine is more easily integrated in specific types of workflow. In addition, the possibility of expanding this method of care delivery to reaching medically underserved areas, domestic and abroad, also remains a viable option in the future. But the question remains, will this model be sustainable in the future for orthopedic surgery? As we are seeing the light at the end of the tunnel for this pandemic, will surgeons continue to offer these visits? And will it make a difference if the surgeon or the patient is offered the virtual visit compared to being forced to have the appointment in that manner? And lastly, I feel that with improved data and understanding of this delivery method, we will be able to develop algorithms to effectively screen patients for those that would benefit most from telemedicine visits. In summary, offering virtual clinic visits have been and will continue to be a tool for increased clinical engagement. Increased patient age and current smoking status are associated with increased Press-Ganey total score. Recommendation of an in-person clinical evaluation is associated with a decreased total and subscore, and variables such as the ADI, distance, BMI, and diagnosis did not statistically influence patient satisfaction. This has been submitted to ASSH annual meeting, and the manuscript is pending for the Journal of Hand Surgery. And I can open it up to any questions.
Thanks, Matt. I have a question for you. Are you going to use telemedicine at the University of Colorado next year? And if so, how are you going to do it?
I will. So there are they have a system in place similar to what's offered here. The reason why I'm going to offer it is, one, I'll be just about 40 miles north of Denver, and there are quite a few communities that quite a few communities that are quite distant from my location. They're in the mountains, etc., or in Wyoming. I will likely screen my patients screen the new patient visits as to those that I feel that would benefit most, in the sense that if they have very nebulous sort of complaints, I probably want to see them in person, because it would probably be difficult to ascertain what exactly is going on. But if it's fairly straightforward, it sounds like carpal tunnel, and they have an EMG or those sorts of things, yeah, I would readily offer it. In addition, I think post-operative visits can be done virtually, as well as the sort of the routine, did the injection work, and discussion regarding, like a pre-surgical discussion.
Okay, great. Other thoughts or questions, comments here? Otherwise, we'll move on. Okay, thanks, Matt.
Thanks.
So next we have Matt Christie with the joints team. Matt, are you able to share your screen?
Yeah, I'm working on it right now. Let's see. All right, is that coming through? Can you all?
Looks good.
That all right? And then let me turn on my video so you can see my beautiful face. All right. All right, my name is Matthew Christie. I'm one of the fellows, one of the joints fellows here. My research presentation is entitled "Return to Skiing After Total Joint Arthroplasty." I have no disclosures, though I do have a disclosure that I am not a good skier. I'm pretty awful, actually. In my home state of Tennessee, this is our one ski slope with 2 chairlifts and about 4 runs. And just as a background, here's my first day in the powder out at Utah. So just for future reference, that's where I'm coming from. I can't answer any questions about skiing, unfortunately. Special thanks to all the folks who made this research project happen. All my mentors in the Division of Adult Reconstruction, Alex Lancaster, Brendan Blackburn, Morgan Miller for everything that they did. So as an introduction, we know that physical activity is beneficial to well-being of patients. That encompasses cardiovascular health, bone quality, muscle mass, balance, coordination, and fall reduction. And ultimately, the goal of hip and knee arthroplasty is pain relief and return of function. As the volume of hip and knee arthroplasties increase over the next 20 years, we know we're seeing younger patients, and we know we're dealing with patients with higher expectations with regards to both pain relief and function. Spend any day in an arthroplasty clinic, and you'll see more and more patients who are expecting to return to their previous levels of physical activity. So there have been a ton of studies out there over the past 20 years that have looked at return to sporting activities after hip and knee arthroplasty. And ultimately, these studies are looking at 3 primary questions. At what level are patients able to perform compared to their preoperative and prearthritic state? Should patients return to an activity given safety profile and longevity of the implant? And how are providers counseling patients, and what are their expectations? So at this point, no studies out there have looked at patient expectations and performance after arthroplasty with regards to downhill skiing. As an interesting aside, I came across this article where a clinician, Dr. Caldwell, put a force sensor into a series of knee arthroplasties. He had one patient who actually engaged in downhill skiing, and they looked at forces across the knee joint while skiing. Some of these forces were almost 3 to 5 times the amount of body weight. And so he was really reticent to recommend that this particular patient engage in any kind of difficult, high competitive level of skiing, and yet she did anyway. So just a little interesting aside from the arthroplasty literature. So what we were looking at was what proportion of patients with prior ski experience return to skiing after hip and knee replacement, and what effect does the arthroplasty have on their skiing ability and preferences. Our primary outcome was prevalence of total arthroplasty patients who returned to skiing after the surgery. With secondary outcomes looking at level of skiing following arthroplasty, complications, and patient-reported outcomes. We hypothesize that only a portion of patients will return to skiing after undergoing total hip or total knee arthroplasty, and those that do return will perform at a lower level than preoperatively. We also hypothesize that patient-reported outcome measures will be higher for the patients skiing postoperatively than those who stopped skiing after surgery. So we put together a digital REDCap survey that was email distributed to our cohort of patients, hip and knee patients who underwent an arthroplasty within the past 10 years. This survey included demographic information, PROMIS measures, and then this detailed inquiry of skiing habits. These patients were 18 years and older, English speaking, and had a total joint arthroplasty in the past 10 years on record. And then we did an additional chart review of patients who self-reported complications or returns to OR. As far as demographics, we looked at number of type of joint replaced, complications and reoperations. And then as far as the skiing data, we looked at a few different time points: the current season, the season after the joint replacement, the season prior to the joint replacement, and then the season 5 years prior to the joint replacement. And we investigated things like level of skiing, grade of skiing in terms of green, blue, and black, limitations to skiing, the time they spent skiing per season and per day, and their expectations, as well as what their surgeon recommended. So unlike some sports where there's a very objective measure of ski of ability, like handicap in golf, or there are some objective measures in sports like tennis and things like that, skiing doesn't really have a very well-established objective measure of performance. And so we use this skier ability chart that is kind of a self-reported, here's what I'm comfortable doing, here's what I'm not comfortable doing, as a way of trying to standardize our patient's ability. So as far as our results, we sent out a little over 4,000 surveys. We got a 17% response rate. That's 745 patients. We split into about thirds as far as never skiers, recent skiers, and remote skiers. And so from here on out, I'll talk about recent and remote being greater than or less than 5 years. So just know that. As far as those two core cohorts, recent skiers and remote skiers, of the recent skiers, about 73% of those patients returned to skiing postoperatively, whereas remote skiers that hadn't skied within the past 5 seasons prior to their arthroplasty, only 12% were skiing. 80% of recent skiers skied the season prior to surgery, and they said those patients that didn't ski, about 55% stated that the pain in the operative leg was the reason that they didn't ski. For the season after surgery, a little over half of recent skiers skied the season after surgery, and 36.5% of patients who didn't ski the first season after surgery, the most common reason was fear of injury. So these skiers who skied the season before their surgery and after, the reason for not skiing was pain in the operative leg preoperatively, and then fear of injury postoperatively were the 2 main complaints. As far as breaking down by joint, about half of total knee arthroplasty patients returned to skiing, Same for total hip arthroplasty. And then the multiple total joint arthroplasty was about 2/5. With regards to our patient-reported outcome measures, for all comers, all survey responders, all postoperative non-skiers compared to skiers, physical function, physical health, mental health, and pain were all statistically significant improvements for patients who skied postoperatively than those who didn't ski postoperatively. Likewise, when broken down into the cohort of patients who skied less than 5 years prior to their surgery, again, patient-reported outcome measures were greater for those patients who skied postoperatively than those who did not. And that's, again, in physical function, physical health, mental health, and pain. Some further notes from our data. Postoperative performance as reported by patients was equal among total hip, total knee, and multiple arthroplasty cohorts. I'll touch on this in a little bit later, but most patients saw performance hit in terms of self-reported performance the year after surgery, and then bounce back partially in the current season. Most skiers were skiing moderate to difficult terrain postoperatively, and most are skiing half a day, although there was a statistically significant increase in the amount that total hip arthroplasties patients were skiing postoperatively when compared to total knee arthroplasty and multiple joint arthroplasty groups. In terms of limitations for patients postoperatively, most were limited by general muscle fatigue. About 40% were not limited by anything, and then 7% were limited by joint pain. And when broken down by type of arthroplasty, total knee arthroplasty and total and multiple joint groups had about an 8% limited by joint pain, while only 3% in the total hip arthroplasty group, and this was statistically significant. Moving on to physician recommendations and patient expectations. Patients reported that their clinician stated preoperatively that they could ski without limitations about half the time. They could ski without limitations a quarter time. It wasn't discussed a remaining quarter of the time. This is compared to patient expectations, and 55% expected to return without limitations postoperatively, about 36% expected to return with limitations, and only 10% didn't expect to return. This is in comparison to what patients are reporting as far as their performance postoperatively. So as I mentioned before, patients were seeing a performance hit as far as self-reported ski level the year right after surgery, but currently they had bounced back as far as their ski level. So while only about half of patients expected to return, most were returning at full capacity postoperatively. So as far as literature out there with regards to other sports, our data was showing about 50% of ever skiers were returned to skiing, far more often in patients who were recent skiers preoperatively. The data is kind of all over the place with regards to other sports. Running has a very variable rate of return to running, from some studies that show less than 20% to some that show about 2/3 of patients returning to running. Golf is pretty consistent. Most patients are returning to golf postoperatively. And this particular study here showed that 100% of patients who engaged in competitive tennis returned to total hip and total arthroplasty. The review study from Wild et al. Showed that most patients are shifting participation from higher impact sports preoperatively, like running, tennis, and skiing in this instance, to lower impact like walking and aerobics. Our data stands in distinction to some of the data in other sporting activities. So in golf, most studies are showing that patient handicap scores are increasing postoperatively at the same time as increasing in their frequency of play. For us, we're showing that really self-reported ski level, with regards to that data, patients aren't really taking a hit as far as performance. So our data as far as patient-reported outcome measures is pretty consistent across the board with other literature out there that shows that patients who engage in activities that they engage in preoperatively, those who engage in those activities postoperatively are showing better patient-reported outcome measures. And this is likely correlation rather than anything else, but interesting to note that that is pretty consistent across the board. In our group, skiers, as I mentioned earlier, only 7% were limited by pain, and this was significantly more common in knee and the combined arthroplasty group. So as far as moving forward with our data, we have probably in the past month or two, finally put this data together. So we're still early in the kind of really synthesizing all the data. So we need to do some further work. That includes comparisons between the never skier and the ski group. Looking at, we haven't done our chart review for the patients that self-reported complications yet. And that really is the crux in terms of answering if it is safe to ski after arthroplasty. So we haven't addressed that yet, and we plan to. We also want to break down some groups as far as total hip and total knee arthroplasty versus multiple joints as far as performance, et cetera, because we do have some early findings that suggest there are some differences in those groups. As far as study limitations, obviously this is a survey study, so there's recall bias, response bias, and survey fatigue for patients. There's some heterogeneity among surgeon recommendations and patient compliance. Every study suffers from sample size deficiency. And then obviously there's a regional bias here in Utah as far as patients who ski. So in conclusion, things that we've found so far, about half of patients who ever skied will return to skiing after total joint arthroplasty. Far more patients will return to skiing if you skied within the past 5 years prior to your arthroplasty. That's about 8 in 10 versus 1 in 10 if you're a remote skier. Skiing limitations, preoperatively, it's mostly operative pain in the operative leg. Postoperatively, it's fear of injury that drives patients from avoiding the sport. Those who ski postoperatively had better patient-reported outcome measures without an increase in reoperations. And total hip patients are skiing longer days and are less likely to report joint pain as a limiting factor when compared to total knee arthroplasty and combined arthroplasty patients. All right, thanks, y'all. We'll open up to any questions.
Okay, if there are no questions, I think we're done. Thank you to all three of you for your work this year and good presentations. Good luck with the remaining part of your fellowship.
Thank you.